I was the first paper I ever write in my career as a ophthalmologist is on OCT because my first rotation in Mass Science Infirmary, I was in the clinic up there where I see OCT every other day. I see so that is actually a relatively rare disease, but Dr. Chu is going to talk about that as well in the UK right now.
Okay, OCP, Ocular Cicatricial Pemphigoid. It is actually a subset of Mucus membrane, and which is a systemic autoimmune disease with antibody against adhesion molecules in the basement membrane zone of the mucous membrane, the skin. And besides the conjunctiva and skin, OCP and obviously MMP shows manifestation in the mouth. That's actually fairly common. Pharynx, larynx, trachea, esophagus, vagina, urethra, and anus. So on your mucous membrane surface. Okay? And on the ocular surface, the OCP manifests as chronic conjunctivitis. And then as the name says, cicatricial, so it's scars. The incidence, 1 out of 8,000 people to 1 out of 46,000. So it's not that uncommon. It's, I used to hear that in a general ophthalmology practice, maybe you see one in a lifetime. Somebody quoted some numbers like that, but I don't think that's true. We have a whole bunch around. I think that it may be under-recognized and under-diagnosed. Oh, yeah.
Hello. Yeah. Okay. So I think it's underdiagnosed, and it's more common in elderly, typically like 60s and 70s. It's reported worldwide. It's probably more common in Caucasian, but it's been reported in all racial backgrounds. The female to male ratio is being reported to be 2 to 1. 75% of OCP patients will have oral mucosa involvement. So it's very important when you evaluate patients' OCP, ask for other things like is anything in the mouth, is it sore in the mouth, sore in the nose, did you have any difficulty breathing even, okay, to any skin lesions that's chronic. So they have chronic cicatricial conjunctivitis. That's the descriptive finding, okay? Conjunctivitis, that's chronic, and it scars. Patient presents with pain, loss of vision, glaucoma, entropion. They may have lash loss, trichiasis, and distichiasis. And if the conjunctiva is tethering the eyeball, you have diplopia. And in the late cases, you have limbal stem cell deficiency. And they have severe dry eyes. They may have persistent epithelial defect of the cornea because of the limbal stem cell deficiency. They can have cornea melt. And the way we stage pemphigoid is as follows. When you see subepithelial fibrosis, like you're starting to see, this is a quiet eye, so it's a little easier to tell that there's lines of the control, and there's a little weak fit. You can see like a line, a white line under the conjunctiva, subepithelial fibrosis, okay? So if you see that only, that's your stage 1. If you have fornix foreshortening, like this one, okay? Stage 2. If you start to get symblepharon, which actually in this patient there will be, it's over here. This is from 2 days ago, last week. And so that's stage 3. And if you start having cornea involvement, if you have cornea involvement like this, conjunctivization, keratinization of corneal surface, then you have stage 4. The other findings, other manifestation, you have this is a patient of a bullous pemphigoid, not a not an ocular cicatricial pemphigoid, but both pemphigoid, and this is what it looks like, these blisters. And they may have non-healing skin ulcers, like if someone says, I have this sore in the back that just doesn't go away. You can biopsy that, and that's may help you establish diagnosis. Oral ulceration, pharyngeal constriction, which is and potentially life-threatening, dyspnea. They may have aphonia, so they can't talk if the vocal cords are involved. And esophageal stricture can cause reflux and worse vomiting, and can lead to other problems. The cause of the pathophysiology of the pemphigoid is being worked to be understood that it's a deposition of antibody and fixation of complement in the basement membrane zone of the mucous membrane. Is formation of bullae. It can be seen when normal conjunctiva is incubated with the serum of patients with OCP. So there's the antibody in the serum that's directly causing the problem. And it is a type 2 hypersensitivity, right? So that's antibody-mediated cytotoxicity, and the antibodies are targeted against certain antigen, and this activates the complement system. So in terms of the differential diagnosis, you have what causes chronic cicatrizing conjunctivitis, trachoma for one, adenovirus and other infections, topical drugs, epinephrine, pilocarpine, beta blockers. Are they really drug-induced conjunctival scarring, or that somehow triggering pemphigoid, or just in coincidence? It's actually not very well known. It's not common. I don't know that I can say that I've seen it in my lifetime. It's something that I always read about, but I don't know how you guys feel about the term pseudo-pemphigoid. I've always felt that they're all pemphigoids. You know, so.
Sometimes it's hard to know even when you get biopsies that come back maybe something. There's a problem with the assessment.
Right, that's another issue with the pemphigoid. We'll talk about it in a little bit. Trauma, surgery can cause scarring the conjunctiva, and if you have a suture, it can be chronic conjunctivitis that's irritating the conjunctiva. Skin and mucous membrane disorders such as Stevens-Johnson syndrome, which is this patient on the left side. This is systemic, the whole thing in the whole body. So you can't really, there's no differentiating between this and Stevens-Johnson and OCP. Epidermolysis bullosa acquisita, or EBA, is one of the differential. Atopic disease, atopic keratoconjunctivitis causes conjunctivitis, causes scar. Lichen planus, linear IgA bullous disease, pterygium, and Sjogren's syndrome. So when you work up patients with pemphigoid, the way you diagnose it is through biopsy. That's the only way. And, well, only way that's easily available. What you see on the conjunctiva in patients with pemphigoid under histopath, you see loss of goblet cell in H&E stain, and you will see the subconjunctival fibrosis. The infiltration of the type of cell that you see include neutrophil, macrophage, and Langerhans cells in the conjunctiva. There will be increased total numbers of mast cells as well in the conjunctiva. Immunofluorescent is, but that's, all those histopath findings relatively non-specific. But if you see immunofluorescent finding, direct immunofluorescence finding of a deposition of IgG, IgA, IgM, C3, C4, any combination of it in the linear pattern in the basement membrane zone, that is how the diagnosis is made. The problem is the sensitivity of this test. It varies in the literature anywhere between 10 to 15%, probably even lower in some studies, I think. And there's another technique called immunoperoxidase technique to stain the antibodies and the complements. It's just not frequently offered by labs. Many places don't have it. And it's probably the cost. I don't know that for fact, but I think there's a cost as well as the difficulty of running these tests. But it's reported to have 80% sensitivity. In terms of working out patients with pemphigoid, you get the complement level may be able to help you if these patients are fixating complements. You see reduction of complements. SED rate can be elevated, C-reactive protein can be elevated. I get the CBC and CMP in these patients all the time because most likely the patient will end up with immunomodulator. So you want to know what their white count's running. You want to know if they're anemic to start. You want to know if the liver and kidney is okay before you put on any of those medications. There is a not commercially available test for antibody against beta-4 subunits of alpha-6 betas for integrin, which is about, among patients with OCP, 60 to 70% of patients has this antibody, and this is maybe the cause of the pemphigoid. So you can ELISA this antibody. The only place is at Dr. Amir's lab in Boston that I know of. So I think he'll do it if you send it there. In terms of the therapy, immunomodulation is frequently required in these patients. The first line is discussed to be dapsone. In the literature, and methotrexate is an alternative. I prefer methotrexate over dapsone. I think the chance of side effects is actually less. Patient tolerates methotrexate better. The dapsone has issues that I'm not that I find less predictable. So methotrexate is generally my first line. Of course, it's not compatible in patients who is pregnant and they need to stop drinking alcohol. Alternatively, mycophenolate also has significant amount of data in the literature. Azathioprine is also acceptable first-line therapy. In terms of the therapy for pemphigoid, topical steroid generally is not effective, and it's certainly not effective as a sole agent, but it can be used as an adjunct if needed, especially patients have significant inflammation. You want to quiet down quickly. It's perfectly reasonable to do so. The use of subconjunctival mitomycin C has been reported in the literature, but it is to buy you some time. It's to prevent fibrosis. It's really not a treatment for pemphigoid. Cyclophosphamide has been used as a first line in the severe cases of pemphigoid in the past. For example, patient comes in, ocular cicatricial pemphigoid with laryngeal stricture. Then it is reasonable to consider cyclophosphamide as your first line together with the IV pulse steroid. The rituximab and IVIG combination is a relatively new concept in pemphigoid because these patients can be difficult to treat, and it has reached to the point that Rituxan and IVIG combination probably demonstrate the highest remission rate in that combination. And the treatment can have a certain range. So you can use Rituxan twice a month, 2 doses, 2 weeks apart, every 6 months. That's how you treat rheumatoid. And that can be one way. Another, to the range of we were just talking about a little earlier, you can give weekly Rituxan, 8 weeks in a row, followed by monthly for 6 months. And then you're going to add IVIG on top of that because with the Rituxan therapy of weekly, that is going to wipe out your B cells. So you're not going to have any immunoglobulin left. So that's why you need to supplement with the IVIG, not so much to use IVIG as a part of the treatment. The infliximab, adalimumab, and etanercept, another TNF inhibitor, there are anecdotal reports and evidence that it helps. But the relapse is very common in these patients, especially not without medications, and they generally require a long course of immunomodulation. In patients with OCP, they generally do not do well with surgery, but if needed, fornix reconstruction can be considered. Lid lash management surgically, such as hypercation for the lashes, that I offer very frequently. They just make sure the pemphigoid is well controlled before doing any of these procedures. The amniotic membrane graft for persistent epithelial defect, that you may need to do even if the eye's red, if there's an ulcer that's not healing. Limbal stem cell transplant generally have very poor outcome in these patients, but it's one of the things that you can consider. Corneal transplant, keratoprosthesis are only effective and successful if the pemphigoid is well controlled. And cataract surgery is frequently required in these patients because, like I said, they present in their 60s and 70s. They have cataract already just from the age. And it's frequently said that OCP can trigger your pemphigoid to act up, so therefore you need to avoid it. Well, sometimes you can avoid it, and the way to approach these cataract is to control the inflammation as long as you can, a minimum of 3 months if possible, and also high-dose oral steroids perioperatively around the time of surgery, and that's my standard for patients with the pemphigoid. I'm more worried about these patients than uveitis patients when you do the cataracts, because they can just start scarring down significantly after your surgery, and you can't really turn it back. They have guarded visual prognosis, be cognizant of potential life-threatening airway involvement, and some cases are quite resistant to treatment, and the prompt recognition and establishment of diagnosis in a timely initiation of the therapy may prevent blindness in these patients. So just to add on to what Ira already talked about on PUK, because of the interest of time, I just truncate this, but this is a potentially blinded disorder, and you see this gutter-like defect with the corneal erosion and the corneal loss, stroma loss in the peripheral cornea. We call that PUK, Peripheral Ulcerative Keratitis, and it is typically a painful condition, and it starts in the peripheral cornea, progresses in a circumferential fashion, and the sclera adjacent to the cornea may also be involved in the form of scleritis. The incidence of PUK is not well understood, but it is very, very rare. And when associated with systemic autoimmune disease, PUK does occur more often in women. And it is associated with the systemic autoimmune disease and the vascular disease that we talked about. And besides those, psoriasis, inflammatory bowel disease, and sarcoidosis, I've seen patients with those conditions that present with the PUK. Herpes zoster, simplex, we covered a little bit, but also also rarely there's association to hepatitis B and C, TB and syphilis also as a rare cause of scleritis that may present as a PUK. PUK is a complex mediated immune response, okay, type 3 hypersensitivity, and these immune complexes leads to complement fixation and cascade leading to vasculitis. And in terms of the destruction of the cornea, you need some sort of collagenase. Okay, that's where matrix metalloproteins come in. That's found in the tissue in patients with PUK. This patient has psoriasis, PUK. And this one, one eye was perforated when we went to the operating room. I glued one eye, the other one I took down the conjunctiva to see what's going on to do the contrasection, but the eye was perforated underneath it, so patched it up with cornea. And the differential diagnosis of PUK, the infectious cause, fungal, bacterial keratitis, but they typically have, don't look like a gutter. And staph marginal ulcer is something that we talk about frequently in your board exams. And so staph marginal ulcer is not thin versus PUK, there's a thinning. The workup for scleritis you would do for PUK. And I always culture these just in case you can isolate any sort of organism. If workup is negative on all these, you call that Mooren's ulcer, which is a progressive inflammatory peripheral corneal ulcer. It's autoimmune process. It is thought to be an autoimmune process, and it also involves more type 2 hypersensitivity and type 3 because of the pathological evidences. And there are two types of Mooren's. Type 1 is usually unilateral. You're relatively benign, that's a relative term. They're still going to have visual consequence when you have ulcers like this, but they're progress slowly, and the eye tend to be not so red. It responds well to contrasection. Type 2 Mooren's ulcer, bilateral. This is rapidly progressive, and they tend to have very, very poor visual outcome in general. Occurs more common in younger patients, and they require systemic immunomodulation in addition to conjunctival resection, but even with that, they tend not to do so well. The Mooren's ulcer, as I mentioned, they have normal workup, normal serology. That's what makes it different from PUK. And in the medical therapy for PUK and Mooren's generally requires immunomodulation, also with the high-dose IV steroids early on. Cyclophosphamide, PUK is one of those cases that I would be open to, not PUK, I'm sorry, the Mooren's type 2. We start off with cyclophosphamide fairly early, but there are consequences to going to cyclophosphamide, anything from cystitis to bladder cancer. And in these patients, more likely they would require long-term maintenance. The topical steroids, remember, has deleterious effect in PUK because it potentiates matrix metalloproteinase. And the matrix metalloproteinase inhibitors that are available to us includes doxycycline, tetracycline, systemically or topically if we can get it compounded. Topical medroxyprogesterone is what I use frequently in these patients who present to the office. And topical acetylcysteine also is a MMP inhibitor. When you have patients with PUK and Mooren's, you do contrasection. So the reason for that is we said it's a complement, it's a antibody-mediated hypersensitivity, right? So it comes to the area through the conjunctiva tissue. So how do you prevent that? You can cut it out. You remove the conj so the blood doesn't get there. So the complex and the antibodies don't get there, and the complements don't get there. And after you cut it out, you put a glue on it. because there are antibody in your tear as well. If you glue it, then the antibody in the tear doesn't get there. That's the rationale. So this patient had lupus, he had a PUK, got a conjure section and glued it. He actually stabilized pretty well, but of course that's in combination with Cytoxan. And we had to stop Cytoxan because of the side effects, and then the PUK kind of started happening around the glue. So Mooren's ulcer has with the visual prognosis of these patients, the Mooren's ulcer, obviously there'll be some visual impact, and in patients with type 2 Mooren's, it's particularly severe. We talked a little bit earlier, Ira talked a little bit earlier about the need for immunosuppression in patients with necrotizing scleritis. So if you think what PUK is, it's kind of like necrotizing scleritis kind of extending into the cornea. So you give it the same treatment, same respect, okay? So the data that makes us need to immunosuppress these patients early on, immunomodulate these patients on, comes from a paper that counted that 29% of death among patients with the PUK and necrotizing scleritis, 29% of the patient died within 5 years of developing these eye findings, and most of them, 2/3 of them, are due to some sort of vasculitic event. But this is before the time of aggressive immunomodulation. So this is from I think the 80s, 84, yeah. And this is not the case anymore today. Among our patients with presenting with necrotizing scleritis, 1/3 of patients don't die within 5 years. It's because of the aggressive early treatment and recognition of these conditions. So in conclusion, PUKs are rare, but potentially sight and life-threatening. And it is the necrosis of the peripheral cornea tissue that occurs from a wide variety of reasons, and prompt recognition of the condition, timely initiation of the workup and the treatment are paramount to the success of helping these patients.